So with this, I end my talk and I ask Dr. Vishal to please take over and start with his presentation. We'll have the question and answers at the end of the session. Thank you. And in case you have any questions, you may pass on the note to one of the coordinators so that he can hand it over to us and we can have it during the panel discussion. Thank you.
Thank you, Dr. Aditya, for inviting me to his wonderful IC, and thank you again for letting me jump the queue. So I'll be discussing techniques and choices of intravitreal antibiotic injections in endophthalmitis. A very basic topic, but nonetheless a very important one. So we all know endophthalmitis is intraocular inflammation, whether sterile or whether infective, involving the vitreous cavity and the anterior chamber. And the standard of care currently involves prompt diagnosis, intravitreal injections, and in non-responsive cases, pars plana vitrectomy. So I'll not go into the details of endophthalmitis per se, but just a brief that it's classified into infectious and sterile. Infectious is exogenous and endogenous, as we all know. And the most common which we see is the acute post-op endophthalmitis caused by gram-positive staph epidermis, staph aureus, and gram-negative pseudomonas, and delayed post-op with Trypanosbacterium acne. So early recognition, as I said before, is critical. High index of suspicion has to be maintained, and a complete ocular and medical history is essential. And a thorough ocular examination, along with ancillary testing like B scan, has to be done. Before we start always with the empirical therapy, but we need a targeted therapy. So always take a aqueous tap and a vitreous tap from the anterior chamber and the vitreous cavity using a 27 gauge or a 30 gauge needle and send it to culture and gram staining and KOH mount. So coming to intravitreal antibiotics. So von Salman first demonstrated efficacy of these antibiotic injections for endophthalmitis in 1944, and in 1974, Piemann actually used extensively the intravitreal antibiotics for endophthalmitis and determined the most important non-toxic dose for the most common antibiotics used. So drug delivery in the posterior segment of the eye is hampered by, we all know, blood-ocular barrier, and routine, intravenous injections and oral antibiotics have a poor bioavailability in the vitreous cavity. So intravitreal therapy in any form, whether it is anti-VEGFs or antibiotics, is a highly targeted modality. It maximizes drug delivery with minimum systemic complications, and it involves injecting drugs through the pars plana, which is a very safe procedure. It has a low learning curve. It's one of the most commonly performed procedures worldwide. The technique is made, this is for youngsters and the beginners, make the patient comfortable, explain the procedure in detail, always and always take a consent, a written and informed consent, along with the relatives. Scrub in, wash hands thoroughly, wear gloves. You don't need to scrub in totally, but that is also recommended. Use paracaine drops, avoid lignocaine as it's bacteriostatic. Apply a lead speculum and prepare the intravitreal fresh. Do not, use stored intravitreal injections. In a phakic eye, you can enter through the limbal route. Otherwise, after injecting, apply a cotton tip applicator to the injection site so that you can minimize the regurgitate of fluid. Examine the fundus and check the eye pressure and the optic disc digitally after the procedure. Do a paracentesis if you are injecting two drugs at a time. Any quadrant can be used. Most common, as we all know, as in all cases of intravitreal injections, the inferior quadrant is the most common. You generally inject around 3 mm in phakic eyes and 3.5 to 4 in phakic and pseudophakic eyes. So this is just a small clip of a video. You just flush the cul-de-sac with 5% povidone iodine, flush it properly. Tell the patient to look towards the other side where you're injecting, to have the gaze towards the other side, the opposite corner. Mark with the caliper. Go inside with a 30 gauge needle. Just put a cotton tip applicator at the injection site so that the drug does not get regurgitated in the subconjunctival space. So the dosage, it's based on how long the intraocular levels exceed the MIC of drug against the possible organism. The safety and efficacy of all these commonly used antibiotics have been extensively studied and documented in literature. Of course, there are special situations like a silicone oil filled eye, where you reduce the dosage to 1/2 to 1/4. And in vitrectomized eye, the dosage might be same, but the frequency of injections will be daily, as opposed to 48 hours or 72 hours in a non-vitrectomized eye. These are the most common antibiotics used: vancomycin and ceftazidime, which we all use in post-op endophthalmitis as the first line of therapy. You add 5 ml of distilled water, mix it well. Take 0.1 of that mixture, dilute it with 0.9 ml of sterile water, mix it well, discard 0.9 and inject 0.1. The same procedure is followed in ceftazidime, amikacin also. the duration and the interval between repeated injections varies from 48 to 72 hours. The special point in vancomycin is do not mix with other drugs because it precipitates. As you all must have noticed, it becomes a white precipitate if other drug is mixed with it. Sorry. So ceftazidime is basically a third generation cephalosporin with a broad spectrum activity against gram-positive bacteria and gram-negative bacteria, including Pseudomonas. And the second most common which we use along with ceftazidime is vancomycin, which is again a glycopeptide active against gram-positive MRSA and multi-drug resistant staph epidermidis. In case of penicillin allergy, you can use amikacin, but the macular toxicity and the retinal toxicity is a concern. Newer intravitreal antibiotics have come in. Colistin, although it is not new, it was launched 50 years before, but recent reports have deemed it very effective against resistant Pseudomonas infections. It acts by increasing the permeability of the cell membrane and could act synergistically with other antimicrobial agents. So most gram-negative microorganisms are susceptible, including multi-drug resistant Acinetobacter and Pseudomonas. Although in patients with kidney dysfunction, the dose has to be titrated. So most of these scenarios we have all seen: acute post-cataract surgery, chronic endophthalmitis, and intravitreal injection endophthalmitis. So these three categories, generally, you can give a trial of intravitreal antibiotics. Most commonly used drugs are again Vanco, Cefta, and you can combine it with dexamethasone also. But if in case there's a filtering bleb-related endophthalmitis, a post-traumatic or an endogenous bacterial endophthalmitis, they will not respond to intravitreal antibiotics, and in most of these cases, surgery is required. I'll skip the antifungal part. Follow-up and outcome. So how do you see the improvement in these cases? And when do you decide whether it is responding, you need a repeat injection, or you have to proceed for a surgery? The signs of improvement are close examination of the AC reaction, the hypopyon is reducing or not reducing, the pupillary membrane over the pupil is retracting. If it is retracting, is there a fundal glow? Is it causing a pupillary dilatation the next day? And the cornea is becoming clearer or more hazier by the day. The final outcome, as described in the EVS study, is the duration of infection, the presentation of the patient, and of course, the virulence of the organism. So the management in EVS was described that you assess the visual acuity. If the vision is PL+, you do early vitrectomy. If the vision is hand movements or better, you give a trial of intravitreal antibiotics. If it improves, you repeat it. If it does not improve, you go for a vitrectomy. That was around 3 decades back. But EVS study and subsequent guidelines continue to recommend PPV only under certain circumstances. Now we know that complete vitrectomy yields far better results after post-op endophthalmitis than those published in endophthalmitis vitrectomy study, because there is considerable better technical equipment, there are better illumination systems, and the optical systems, the wide-angle systems are much better, and the surgery is much more safer. So there is a clear trend towards early and complete vitrectomy. Of course, if in your setup you don't have an in-house VR surgeon or a VR OR, of course you can give an intravitreal antibiotic, but promptly refer so the VR surgeon can attempt the surgery as soon as possible to give the best results. Thank you so much.